Hi, everybody. Welcome. My name is Michael Valaire, and I really appreciate you being here for this presentation of Health Literacy 101 and Introduction. In general, I give this presentation for those who are new to the field of health literacy, for those who just want a little bit of an update. And so, without further ado, here we go. So, what are we going to talk about today? We're going to talk about health literacy. We'll start off with some definitions, what comprises health literacy, what are the components, and then some examples of how this plays out in real life. We're going to take some data from national surveys. These surveys are a little bit old, but they're really the best data that we have. And subsequent studies have shown that these numbers have not really improved greatly, so these numbers actually have validity. We're going to watch a little video clip called Health Literacy and Patient Safety, Help Patients Understand. This was produced by the AMA Foundation years ago, but I've always found it very valuable for people to get that sort of perspective from the person who has some literacy issues. And it's a very powerful video. It runs about 5 or 6 minutes long. We're going to look at some statistics, prevalence of health literacy, and costs of health literacy, both from a systems resource perspective and also the human toll that limited health literacy can take. And then we'll look at an example of whether we ought to screen for health literacy. Okay, let's go ahead and jump in. So let's start off with some definitions. Literacy. People always ask, well, what's the difference? Literacy and health literacy. They are overlapping concepts, but they are actually distinct in terms of the definition. So for literacy, lots of different definitions we could use. This one works pretty well, using printed and written information to function in society, to achieve one's goals, and to develop one's knowledge and potential. It's essentially your ability to read and write and function in a society, to be able to understand how to navigate, how to purchase things, interact with one another. Basically, as I said, kind of your ability to read and write. Health literacy, now, there's a lot of different definitions here. It really is an interaction between the skills of the public and the demands and expectations of the health sector. So when those things meet, we kind of have our optimal situation. But quite often, the demand of the healthcare system is way up high, and the skills of the public, what we're asking people to do, is really well below what we're kind of asking. Because many times, we put really unrealistic burdens on people. We'll also see some examples of that in just a moment. So here's a definition that's been around forever, and really, I think it's generally acknowledged that this one is a little bit out of date. The degree to which individuals have the capacity to obtain, process, and understand basic health information and services needed to make appropriate health decisions. On its own, it's not bad, but the problem is that it puts the onus and all the focus for health literacy directly on the individual, and there's no element of responsibility on the system itself. So these two definitions are from Healthy People 2030. In this latest iteration of Healthy People, they decided to do two definitions, one for personal health literacy and one for organizational health literacy. So here's the definitions. Personal health literacy is the degree to which individuals have the ability to find, understand, and use information and services to inform health-related decisions and actions for themselves and others. So you can see quite a bit of reference back to that original definition. But then there's also this companion organizational health literacy definition, which is the degree to which organizations equitably enable individuals to find, understand, and use information and services to inform health-related decisions and actions for themselves and others. So the key part here is that phrase, equitably enable individuals. So we're going to get into that in just a little bit. But again, we are the healthcare system. We're the ones with the knowledge. We're the ones who work in this space all the time. Patients and people coming into the healthcare system, they spend a fraction of their lives interacting with healthcare and the healthcare system. So the language, the jargon, the way to navigate the system, understanding how to take care of yourself, issues of self-efficacy, understanding how to take medications, how to manage chronic illnesses, all of these things are very, very complex concepts. And quite often, we as the healthcare system really don't do a great job in terms of explaining how these things work, in terms that people can actually understand and act upon. So let's press on here. Another way to think of health literacy is that it's a state, not a trait. And here's a good example of that. So imagine you had a test, a scan or a blood test or an x-ray or an MRI, whatever it was, and the doctor says, come on in, we'll talk about your results. And you walk in and you're in the exam room and they say, I'm really sorry, but the results of your test came back and it appears that you have cancer. And so I can guarantee you right at that moment, your health literacy is going to drop because your mind is not going to be focused on what the healthcare professional is saying. Your mind is going to be going every other which way. Oh my gosh, what does this mean? Am I going to live or die? What about my family? What about everything else? How am I going to make it? What am I going to do? Am I going to be okay? So all of a sudden, that cognitive engagement that you would normally have in that situation and being able to understand and have a productive conversation, it really kind of flies out the window. And so this is what we mean by health literacy is a state, not a trait. And we'll see some of the other things in a short bit that tend to affect and modulate health literacy. So, health literacy components. What all is involved here when we're talking about health literacy? So we're looking at reading and writing. We're looking at listening and verbal communication skills. And this is between patient and provider, whatever term you use, healthcare professional, healthcare consumer, whatever that term is that you're looking at. These are really two-way streets, conversations. I mean, this presentation that you're watching is one way. I mean, obviously I'm recording it and there's no way for you to ask me questions and have any kind of dialogue. So this is a kind of a didactic one-way lecture presentation. That should not be the way things are in a healthcare setting. We should be really looking at what does that exchange look like. There's information given from the healthcare professional to the individual. There may be some questions asked. If the healthcare professional is using effective tools such as teachback, they may take a pause, should take a pause, and check to see what the understanding is. And there's a whole process around that. But it's a way to have an individual repeat, or not really repeat, but explain it in their own words, what has been told to them so far, and what do they understand. And then the healthcare professional can evaluate that based upon what the individual has said back and identify those gaps and take responsibility for any miscommunication and try to communicate that in a different way so that you teach to understanding. Numeracy. This is the ability to deal with numbers. Remarkably difficult. We'll see the statistics on numeracy, also known as quantitative literacy, when we look at statistics in just a moment. But numeracy really involves things like computational skills. If you're asked to take 2 pills 3 times a day, what's your total number of pills? If you're taking a medication once every 4 hours, how many doses should you take? There's dosing charts where you have to see weight and age or things like this, especially for children. To be able to really kind of figure out these things requires a higher level of numeracy. And then also interpreting and evaluating risk. And these are things that are very important when you need to make some decisions based upon what kinds of treatment you want to have, what you want to do in certain clinical situations, choices of medications. The famous example is, this pill works in 1% of the population and it's only $5. This pill is twice as good. It works twice as well, but they cost $100 each. Well, when you say it works twice as well, you're talking about an increase of 1% effectiveness to 2% effectiveness. So really not a big gain. And the cost obviously is a major factor. But there's a whole set of language and framing issues around this notion of risk and making decisions around that we as the healthcare system have a real responsibility for making sure that these things are discussed in a way that means something to the individual. And then, of course, self-efficacy, your ability to take care of yourself. If you are diagnosed with diabetes or asthma or cancer, there are certain things that you need to do to maintain your health or maintain a strong sense of health, as strong a sense of health as you possibly can. And for things like diabetes, to keep your blood sugar in a certain range and make sure that you don't suffer some of these really bad side effects that can come from that. Those things are remarkably difficult to teach, and they really take a one-on-one approach, testing, making sure that the language that you're using, the teaching aids, the pictures, the descriptions, the brochures, the videos, whatever it is that you're using to teach, that works for the recipient. Some people like to read. Some people learn best by hearing. Some people by watching videos or seeing pictures. Some people need a combination of all of those things. So that notion of self-efficacy is a component of health literacy, and there's a major component that puts the onus on us as the healthcare system. Some other things that play into health literacy: culture and belief systems. Who you are and how you grew up and what you believe in is not necessarily the same as all those things for me or for anybody else. And quite often in certain cultures, there are norms that we as members of the healthcare system need to make sure that we understand. This is a part of what we would call cultural awareness and cultural competency. There's a really great book that illustrates this. It's called The Spirit Catches You and You Fall Down by Ann Fadiman. It tells the story of a family, a Hmong family, that's Hmong, a Hmong family in Northern California in the 70s or early 80s, about 40 years ago anyway. And there's a little girl, she had a seizure. She was 2 or 3 years old at the time. And so the family took her to the local community hospital. And she was diagnosed, and they said that she had epilepsy and she was going to have these seizures and she needed to take certain pills. Well, the family believed that the source of her illness was a spiritual reason or a spiritual cause, that she had suffered a fright from a loud noise and that her spirit had left her body and that an evil, malevolent spirit had captured her spirit when it came out. And so now she had this affliction. And when you translate from Hmong, how the family named her condition was the spirit catches you and you fall down. The book really talks about the clash between these two systems, where we have the Western medicine system saying, this is what it is, this is what you need to do, and the Hmong family saying, this is what it is, and this is how we need to treat it. And there was never really a meshing of those two ideas or those two cultures to be respectful of one another and understand one another's position and come up with something that worked together for both of them. So again, some other considerations are this mismatch between what we are asking people to do and the skill level that they bring into that equation. Some things are fairly simple. You could say, Valère, you need to stop drinking sodas. I don't really drink sodas, but if I were drinking a lot of sodas and I was pre-diabetic, that might say, you need to stop drinking sodas. Okay, that's pretty straightforward. The doctor could say, Valère, you're overweight, you need to lose 40 pounds. Okay, well, how do I do that? So we need to make sure that we understand what it is we're asking and that we test in whatever way we can to get a sense that the individual with whom we're interacting understands what it is we're discussing, and that it is of importance to them, and that what we're asking them to do is something that they actually can act upon. And then, of course, all the other things about encouraging questions and testing for, or actually assessing understanding through tools like Teachback and those sorts of things. This mismatch of reading materials, reading levels, is one thing that in health literacy we tend to put quite a bit of emphasis on. It's not the only thing. It's certainly, though, a very important component. So if somebody is reading at, let's say, a 5th or 6th grade reading level, which is pretty typical, and we give them a brochure, here, take this brochure, and the brochure is written at a 14th, 16th, 18th, 20th grade, yes, those levels actually exist, 20th grade reading level, there's a mismatch there. And the likelihood is that thing's going to go in the garbage or in a drawer somewhere. It's not going to get read because it can't be read by that person. And so making sure that things are readable, accessible, understandable, and actionable in our written materials is very, very important. Health literacy also has a very strong relation to health disparities. This is especially true in areas such as access to health care. If we don't understand how to get and use and keep a health insurance policy, whether it's Medicaid, Medicare, or private insurance, then we have a problem. That person is now being put at great risk because they don't understand how to use that policy. And if they did understand how to use that policy and were able to use it, that's a lifesaver. And if they can't, then that's a health disparity that they're experiencing. Health literacy also has a strong relation to safety and quality. These are pretty evident things in terms of instructions and warnings. Take this, don't take that. If you take this medication, don't do that. When you leave the hospital after a surgery, make sure you do A, B, and C. Don't do D, E, and F. These things are remarkably closely tied into safety and to quality care issues. And when we don't ensure that there's understanding, then we're getting into these issues of safety and quality. So here's my buddy with one drink. You know what you mean, but does he? So he says, my doctor said only 1 glass of alcohol a day. I can live with that. I believe I would be in a coma if I had half of what was in that glass. The point here is just because something is clear to you, it only means that it's clear to you. It does not mean that it is clear to those you're speaking to. So this gentleman, of course, this is an exaggeration and a bit of a joke, but the phrase was, you can have 1 glass of alcohol a day, but there was no indication of how much. What's a glass? Is it a 1-ounce shot of liquor? Is that a 4 or 6-ounce glass of wine? Is that a 12-ounce bottle of beer? What does that actually mean? So those sorts of things, it is our responsibility to think forward and make sure that we are being very, very clear. You can have 1 shot of liquor or 1 6-ounce glass of wine or 1 12-ounce bottle of beer per day. If the doctor had said that, then obviously this situation would not have taken place. So there are a few little potential scenarios, and actually I think these are for real. So an 89-year-old man with dementia is diagnosed with an ear infection and is prescribed an oral liquid antibiotic. His wife understands that he must take 1 teaspoon twice a day. After carefully studying the bottle's label and not finding administration instructions, she fills a teaspoon and pours it into his painful ear. I cannot fault the wife in this situation, in this scenario, because we, as the healthcare system, did not say, take by mouth or swallow this or anything similar to that. It just says, take 1 teaspoon. And he's got an ear infection. Here's the medicine. Here's where it hurts. This does not seem like an outlandish stretch to see that mistake could have been made. And these things happen all the time. Here's another one. Mr. G, 45, Hispanic immigrant, native Spanish language speaker, has a job health screening. He's told that his blood pressure is high and he can't work until it's controlled. He's given a beta blocker and a diuretic and instructed to take each once a day. That's what's on the prescription bottle of each one. Take once a day. 1 week later, he presents at the emergency department. His blood pressure is very low and he's dizzy. The doctors can't figure out why. A Spanish language speaker in the ER, or in the emergency department, asks him how many pills he took each day. 22, says Mr. G. In Spanish, once, or once, means 11. And so here's a person who, in their language, only recognized one word on that label, and that was once. We'd say once, which means 1 time. He saw once, which means 11. So he took 11 of each one. It begs the question, can low health literacy or limited health literacy kill you? I would submit that yes, in fact, it certainly could. Here's one more little scenario at a teaching hospital. An intern writes in a patient's problem section of the medical chart, speaks no English. The attending physician writes a note back and responds, your problem, not his. Because somebody does not speak our language, that is not a patient problem. That is a barrier. That is a challenge. That is something that is keeping us from communicating. And so the way we really need to look at this is to say, all right, this person doesn't speak English. We here at the hospital, hopefully, have a language access policy and program. So if they need somebody to come in and interpret, whether it's some other language, that you would bring in that third party and that they would interpret the conversation between the clinician and the patient and their family members. That's all who happens to be there. Here's one little quick bit of information. In healthcare, there's a distinction between how you take the spoken word from one language to another. That's called interpreting. If you change the words from one language to another in written form, that's called translating. So make sure that you understand these two concepts, translation and interpreting. They are distinct entities, and it's important to understand these distinctions. So I mentioned earlier on we were going to take a look at a video. This one, as I said, it's kind of old, but it really does still hold up. And what I would like for you to do as you're watching this video, it's a bunch of clips. Listen to the stories that the people are telling. There's some titles on there. They'll give you their name, what they do for a living, and at what grade level they read. All of these individuals telling their stories have some challenges with literacy, and they really try to focus on that. Most of these are really how that challenge with literacy relates to their being able to take care of themselves in terms of their health. All right, so here goes the video. Go ahead and watch.
Missed dosage and didn't realize it. I was in the hospital a lot. When they did give me medicine, I didn't take it right. I admit to it. I just didn't understand them, and I didn't have the nerve to ask them the right way of doing it. I just didn't have the nerve to ask them, and I didn't want anyone to know I couldn't read.
We had a child that was physically handicapped that I had to do physical therapy on. I would show up on Tuesdays instead of Thursdays for the appointment. I would be exercising the wrong side of the body.
I had an abscess in a ear one time. Well, I had to fill out forms and I couldn't fill out, so I didn't go. I come back home. I ended up having to go to the emergency room that night because it burst.
Can you imagine what it's like, you being a patient and sick, and you know that you have limited skills, okay? And you're talking to an intelligent doctor like yourselves. And these people are using words that you really don't know because they're not speaking in layman's term, okay?
Right.
Most doctors are just presuming that everybody's intelligent as they are, and that is just not the case. So what you do, you come out of that room, that examination room with this intelligent woman or man thinking, God, I hope I don't make a mistake with my medicine because I did not understand anything he or she said to me.
One capsule.
That's right. One capsule.
One capsule. I don't know what this is.
Twice?
Twice daily.
Okay.
Okay.
So how would you take this?
When I see it's not on, I tell you how to take it. It say take it twice daily, but it don't say what time to take it.
Which one is which and what you take them for?
That looks like my medicine that he gave me for the morning. I take that and the little pill that, oh, this is this is Lipian, isn't it? Yeah, that's Lipian.
Okay. And what do you take that medicine for?
Don't ask me. He puts me
Okay.
on there and I just take it.
Okay.
Anything he tells me to take, I'll take it.
Okay. So you trust him?
Oh, you better believe it with my life.
Hypertension means, if I asked you what that was? Because when I look at this, I think, well, maybe you have hypertension, and I've been taking care of that for a long time.
Hypered? Hypered?
Like you're hyper? What does being hyper mean to you?
That's where you can't be still. You always got to be doing something.
Do you think I think you're hyper and have hypertension?
I don't know. That's what I consider it.
Okay.
It being, you know.
Okay. But you know you have high blood pressure. Okay. But hypertension doesn't mean the same to you. So if I ask you if you have hypertension, you're going to just think I think you're jumping around on the chair or something like that, something different.
Just being hypered, you know.
Okay. All right. Well, I haven't done a very good job teaching you what hypertension is, because I think you take that medicine for your hypertension, and that's one of the things that I try to work with you on is your blood pressure. And high blood pressure and hypertension, to us, is the same thing.
The same thing.
At approximately 30 or 31, I went into the gynecologist and complained about part of this not working correctly. And he said, we can repair that. Great. I didn't ask all the right questions. When I showed up 2 weeks later at the admissions office at the hospital, they put enough papers in front of me. I'll bet there were 5 papers that I needed to sign. Well, I wasn't going to say, excuse me, but I don't read really well, and I certainly don't read fast, and I'm concerned with some of these words. To me, it was lines and circles over sheets and sheets and sheets. And I wasn't going to reveal my sense of stupidity, so I signed everywhere they told me to sign. Never read it. And then a couple weeks later, in the follow-up office visit, the nurse said, how are you feeling since your hysterectomy? Now, I acted as normal as I could. Inside, my mouth fell open, and I thought to myself, how could I be so stupid as to allow somebody to take part of my body, and I didn't know it?
If you have a reading problem, you go to the doctor. That can be very scary. It's like a nightmare. You walk in that office, and most people, if you realize the first thing you're going to have to do if that's your first visit is fill out a form. Your heart beats real fast. You're scared. You don't know what to do. You want to turn around and walk out. I have.
You have panic attacks. Did I do it right? Is this done right? Am I imagining things? Do I go back over and check it again? I've caught mistakes that I made, simple mistakes.
It paralyzes your thoughts completely to think that you may say something or something is put before you to read and you can't read it. I mean, you live with that on a daily basis.
People sooner or later will discover, and that is your most greatest fear. Mm-hmm. What day is it going to be when somebody discovers you can't read and write?
I would get mad about something and blame them that this is not the right place for me, you're not respecting me, and walk out. And it had nothing to do with that. It was just I need to cover that I couldn't read this. I didn't want them to know that I'm walking out because I can't read.
So you found solutions that
Yes.
sort of make it work and hide the
Yes.
real problem.
Yes.
So that others won't notice.
Right.
Doesn't that take a lot of your time?
Yes.
Doesn't it take a lot of effort for
A
you?
lot. Very emotionally. Yep.
It drains you?
Yep.
Okay.
I am married to an engineer now, and this man has some health issues, so we are in the doctor's office from time to time. We will walk out of the doctor's office, and my husband, with all of that left-brained intellect, will say to me, "What did the doctor say? What am I supposed to do? I don't understand."
I'm going to say, well, one of the things that you can do if you have a really bad pain, I mean, where you can't stand on it and it's really getting in your way, is to use what I call, this is my little pain protocol here. It has ibuprofen, which decreases those little cells I was talking to you about, the inflamed part, and your Tylenol that just works on the pain. Yeah. And the I is for ibuprofen and T is for Tylenol. And this just shows you how to do it over the course of the day. For breakfast, lunch, and dinner, there's an I, so you use ibuprofen.
Right.
Because you have to have something on your stomach.
That's right.
With that one.
Yeah.
Because this one will irritate your stomach.
Yeah.
So in between meals and at bedtime, you use a Tylenol.
Right.
This way you get something every 3 hours. You don't overdose on either one. So it's IT, IT, IT. And if you do that for a couple of days when it's really bad, then you can just go back to your regular regimen. But this usually breaks the pain pretty nicely. So I know you have a lot of friends with arthritis. How would you explain it to them?
Well, for breakfast, I take I. 10 a.m., I take T. Lunch, I take I. 3 p.m., I take T. I at dinner, and T at bedtime. Is that correct, Doctor?
That's going to work just fine.
Thank you.
Okay, so we're back. Now, normally when I'm doing this presentation live, this is where I call on people to share, whether they want to or not. But I think during this video, there were some very heartbreaking stories and some very illuminating types of stories. At the beginning, we had the woman saying, "I didn't take my medication right. I admit to it." And that word admit always kind of sticks with me, because you think, well, when you admit to something, you're saying, I broke the glass, I admit it. I ran the red light, I admit it. That you did something kind of with an intent to do something wrong. And frankly, just because you don't understand the instructions that are written on a prescription label is not kind of a premeditated act on your part at all. There's the stories of how these individuals with limited literacy skills have to hide that. The gentleman who says, your greatest fear is the day that people find out, and they will find out. He just sort of admits that it's pretty much a foregone conclusion that someday it's just that kind of pressure having to live with that. And I have to say, I can't imagine what that would be like, just having that fear in you on a daily basis of when everybody would, or anybody would discover that you can't read or write. And then, of course, the woman who didn't realize it, but had a hysterectomy because she couldn't read the consent forms. And consent forms, this is a major challenge. This is really a major issue in healthcare. There's been a lot of work done in this area, and a lot of advancements have come to that, but it's still a major issue. And I hope that at least this video gave you a little bit of insight into what it feels like to walk in somebody else's shoes for a little bit. It's very difficult, very, very difficult. So let's move on. Let's take a look at some statistics of literacy and health literacy. As I mentioned, two studies. These are old studies. The 1992 NALS study, the National Adult Literacy Survey, which did strictly literacy levels. And then in 2003, the NALL, National Assessment of Adult Literacy. They added a health literacy module. So the statistics that we get, that we use here, are from this 2003 study. Now, there are no further NALL studies planned, but there is the PIAC, P-I-A-A-C, that is done internationally, and that assesses literacy skills in countries all around the world. So the URL is there for you. Go ahead and take a look at that if you're interested in compared literacy skills, and you can see really there's not been an awful lot of progress over the years. But let's jump into statistics here. Okay, so the literacy levels that we're using are these 4 levels: below basic, basic, intermediate, and proficient. And you can see the descriptors there for each one. When we talk about the healthcare system and people's ability to navigate that healthcare system, we really need to fall into this proficient level. Anything less than proficient, there's going to be a lot of components that we miss, that we don't understand, and that we're not able to act upon. And so to really effectively navigate the healthcare system, one really needs to be in that proficient level. So from the NALL, the 2003 NALL, these are the literacy findings. We'll look at health literacy in a moment, but these are the literacy findings. So what percent of the U.S. adult population fell into the bottom 2 categories? Remember, those categories were below basic, basic, intermediate, and proficient. So the below basic and basic, these are the 2 bottom categories. And in terms of prose literacy, which is just your ability to read sentences and paragraphs, just think about reading a book, a magazine article, a brochure, or something like that. Prose literacy, 44% of the adult population fell into the bottom 2 categories. Document literacy. This is your ability to find information on a page, whether this is a dosing chart, a map, a BMI chart, some kind of form where you have to fill in information or get information. Document literacy is even lower. That's at 34% of people fall into the bottom 2 categories. About 1 in 3 fell into the bottom 2 categories. And then quantitative literacy or numeracy, which we talked about earlier. This is your ability to use numbers to understand and evaluate risk, those sorts of things. 55%, more than half of the adult population are in the bottom 2 categories in terms of quantitative literacy or numeracy. So now let's take a look at the health literacy statistics. Those were the literacy, and these are the health literacy. 36% of the adult population fell into those bottom 2 categories. You can see the split there. So a little more than 1 in 3 individuals are in the bottom 2 categories. Here's the one that always strikes me, and this is the one that I kind of use all the time. And if people need any kind of persuasion about why we need to invest the effort in health literacy that we do, 12%, which is about 1 in 10 adults in the United States, are considered proficient in health literacy. 1 in 10 U.S. adults is considered proficient in health literacy. So that means almost 9 out of 10 are really not able to effectively and completely navigate the healthcare system, take care of themselves, make those decisions, obtain the information, act upon it, etc., to be able to really be considered health literate. About half the population had intermediate health literacy. And then, no big surprise here, women's average health literacy scores were 6 points higher than men, and 4% more men fell into the below basic category. So there you are. Now, this next one I want to be really careful about. Our heading says, who has poor health literacy? And what we really need to understand here is that in each one of these groups, it doesn't mean if you are 65 years of age and older that you have basic or below basic health literacy. It means members of that group tend to have a higher incidence of low health literacy, okay? So we have to be very careful about that distinction, because we can't just look at somebody who is 70 years old or 80 years old and say, oh, poor health literacy. Not necessarily true. That group, as I said, the incidence in each one of those groups tends to be higher, but there's not an automatic correlation between the two. So we can see the statistics here. Nearly 60% of those who are 65 years of age or higher fall into those bottom two below basic health literacy categories. The tendency is that those who get health insurance from an employer tend to have higher health literacy. Those on Medicare or Medicaid or who have no insurance tend to have lower health literacy. Hispanics, representing about 16% of the adult population, represent about 35% of those in below basic health literacy categories. And those living at or below the poverty level, which is about 17% of the adult population, they represent about 43% of those in the below basic health literacy category. So you can see in each one of these categories, there is a tendency for individuals in each one of those groups to have limited health literacy. Does not mean because you're in one of those groups that it's automatically you. I cannot stress that enough. And then studies have shown 75% of those who self-reported poor health fall into the below basic health literacy category. So why is this a BSD? BSD, oh, that stands for big stinking deal. So why is this a big stinking deal? Why does health literacy matter? For a lot of reasons, and let's go over a couple of those now. Those who have limited literacy skills, they tend to report poor overall health. We saw that on the previous slide in terms of the statistics. Their ability to manage chronic diseases, that's a challenge to be able to manage those, because as the healthcare system, we're the ones who need to explain that. And if we don't do a great job, our demand is way up high and their capability is way down low. That's a mismatch, and we are not going to be communicating. And so the individuals with limited health literacy skills would tend to have a poorer ability to manage those chronic diseases. They also, as a group, tend to have poorer outcomes. They're less likely to understand their diagnosis. And so what does that mean if you're telling me I have asthma or diabetes or high blood pressure or anything else? They're less likely to have screening and preventive care. Again, this kind of goes back to that issue that we talked about with respect to getting, understanding how to use, and keeping and using a health insurance policy, whether it's Medicaid, Medicare, or private health insurance, anything along those lines. Health insurance is a pretty complex concept. And so to be able to understand that, it's a health literacy issue. They tend to present in later stages of disease because, again, we learn what are some of the warning signs. And quite often, we don't take those warning signs. When you're at a certain age, you need to start having certain screening tests. And of course, with limited health literacy skills, you don't get and understand and act upon those particular messages. Those with limited health literacy also are more likely to be hospitalized. And when they're discharged, less likely to understand very complex discharge instructions. And so they're more likely to be re-hospitalized. And so again, those are some of the kind of reasons and statistics, or facts, I should say, about those with limited health literacy. Let's take a look at some resources and cost and dollar issues here, because we'll start to connect some of these threads here. Very early study by Robert Friedland at Georgetown showed that about $73 billion each year, billion with a B, is spent unnecessarily because of health literacy issues. A later study by Vernon and colleagues at University of Connecticut bumped that up to about somewhere between $106 and $238 billion in unnecessary costs annually. A lot of people dispute the veracity or the correctness of any of this data. I think that what's not in dispute, though, is that there's an awful lot of money spent each year because we, as the healthcare system, don't take health literacy into account and really try to communicate as clearly as possible. What that number is, there's always going to be a lot of debate about that, but the fact remains there's quite a bit that is spent unnecessarily each year because of this. When we look at things like the cost of chronic disease, about $1.1 trillion in direct treatment is spent each year. And then if you add in the indirect costs, which would be missed work time, disability, all the other associated types of costs, that number inflates up to about $3.7 trillion. And that's about 20% of our gross domestic product. This is a staggering number. 60% of Americans live with a chronic disease, and 40% of those have two or more. 90% of those 65 years of age and older have a chronic disease, and 77% of them have 2 or more chronic diseases. And then about 7 out of 10 annual U.S. deaths are due to chronic disease. So we can, as I said, start to connect some of these dots, especially with this statistic here. 90% of those 65 years of age and older have a chronic disease. So the need for this particular age group to understand how to take care of those chronic diseases is quite high. But you recall from the previous slide, those 65 years of age and older as a group tend to have a much lower health literacy capacity or skill. I think it was 60% fell into the bottom 2 categories. So at the end of the day, those who really need to understand those instructions are the ones who are least suited or least able to be able to follow those instructions that are not put out simply, plainly, in an understandable, actionable fashion. So a few more statistics. About half of the American adult population is not reading above an 8th grade level. And most patient education materials are written beyond the recipient's ability to read. I mean, on average, a while back, somewhere between 9th and 12th grade reading level or higher. So this next one was from a study published in JAMA. 26% of individuals could not understand when their next appointment was when it was written on an appointment card and given to them. 42% could not understand the instruction, take on an empty stomach. And 60% could not understand a consent form. I personally believe that number is actually a lot higher. I consider myself to be pretty well educated, and I've read through some consent forms, and there's a decent number of places that I still stumble on and have to ask questions. And then a few more facts just to sort of stir in. 381 languages that are spoken or signed in the United States. 47 million foreign-born people who live in the United States. 60 million Americans who speak a language other than English at home. 24 million Americans who have limited English proficiency, and 75% to 90% of patients in the 2 lowest reading levels describe themselves as being able to read and write English well or very well. So this last statistic to me is really probably one of the most insidious ones, because you can't just ask somebody, so do you read and write really well? Sure I do. As you saw from that video, there's tremendous shame associated with limited health literacy skills, or just limited literacy skills. People are simply not going to tell you, hey, I'm here for my appointment, and by the way, I can't read and write. That's just not going to happen. And when you have nearly 9 out of 10 patients who fall into the bottom category saying that I can read and write English well or very well, you'll use that as a cue to say, oh, okay, well, I can just talk in normal language like I do with all my other healthcare colleagues. I'll use jargon and long sentences and lots of subordinate clauses, and I'll talk really fast, and I won't take time to ask questions because you said you can read and write very well. So let's just get this going, because I got another patient I got to see in a couple of minutes. Like, a lot of information I got to give you, and blah, 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 blah. And guess what? That's just going to go right over their heads. And so that whole interaction was for naught. And these other ones regarding language, what language people speak at home. As you recall, earlier on in our presentation, we talked about the intern who wrote in the patient problem section, speaks no English. Guess what? That's not a patient problem. It's just a challenge. And so when we have this significant portion of people who don't speak English as their first language or have limited English proficiency, it's a barrier. Simply, it's a barrier. There's no judgment there. It's just a barrier. And it's our responsibility as the healthcare system to deal with that barrier. How do we get around this? Language access programs is one great way. Lots of other different strategies, but it's just something that we as the healthcare system, as the individuals who are the keepers of this knowledge and the ones running the healthcare system, it's our responsibility. We're the ones who need to stand up and take responsibility and say, you know what, we're the experts, and so we need to make sure that we are being very clear and concise. A few other issues. Cognitive impairment, whether that's just as a result of age or disease process or medication, which is on the list there. Quite often, we're just not able to focus and concentrate or understand things that somebody might think that we'd be able to understand. Hearing and visual impairment. If you're in that doctor's office and you have issues with hearing and that doctor is talking very quickly, everything sounds muffled. If you tend to read lips or take visual cues from that and they're turned away, they're looking at their computer, which unfortunately happens quite a bit, this is going to affect the quality of that interaction. Medications, as we discussed. Stress. You heard the story from the person in the video who said her husband, with all that left brain intellect, walks out of the doctor's office and says, "What did he say?" Studies show that by the time you hit the door and walk out, you've probably forgotten about 50% of everything that was communicated during that primary care visit. And this is not just for primary care. This is about reading information. This is about just understanding any concept within the healthcare system. And then we talked about this, the shame around limited literacy. 78% thought that they should just hide it or cope, and you saw that in the video. 77% never told their doctor. 2 out of 3 never told their spouse, and 19% never told anyone. So again, these statistics, they're sobering, very sobering. Then there's an issue where people are like, well, let's just do screening tests and let's find out who has limited literacy. Then we can just talk to those folks one way, and the folks who are really educated, we don't have to worry about. What a headache. My recommendation, and the recommendation of a majority who operate and work in this field, is that we should just use what we call universal precautions, which is essentially treat everybody as if they're low literate. And that doesn't mean to be condescending. If anything drives me more bananas, it's when somebody says, oh, let's take this and dumb it down. We're not dumbing things down. We're using plain, understandable language. So what's plain language? Plain language is language that we use to describe something so that somebody understands it the first time they hear or read it. Living room language is another example. These are all just ways to communicate that we don't have to try and prove we're really smart by using big words. We can use simple, kind concepts, short sentences, 1 or 2 syllable words, to stop for a moment and assess and make sure that people are staying with us, because healthcare is pretty complex stuff. So this is what universal precautions is really about. It's just removing barriers. Again, health literacy really is about identifying and removing barriers so that we're all operating on that same field, that we achieve something that we like to call health equity, that everybody has equal access, that everybody has an equal ability to thrive, and it doesn't depend upon any particular factor. Who you are, where you live, where you come from, how much money you make, whether you work, what color your skin is, where you were born, where your family comes from, your gender, any other issue. None of that matters. Everybody should be able to access and use quality health care and be able to live a healthy and happy life and thrive. If you do decide that you want to screen, 2 of the tools that are available, one's called the NVS, Newest Vital Sign, not so new anymore. Barry Weiss and colleagues developed this. Essentially, it's an ice cream nutrition facts label, and there are 6 questions that take about 3 minutes. You can get an assessment of where somebody's literacy skills are after that. Or Lisa Chu and colleagues, who had a series of 3 questions, and this one tended to test the best. If you ask somebody, how confident are you filling out forms by yourself? That tends to correlate pretty highly with where their literacy levels are at. So again, when this issue of screening comes up, the recommendation really is just use universal precautions. Be clear, be simple, be straightforward. Make sure people are understanding you. Ask questions. And so there you are. If you have any questions, you can enter those into the chat box available on this presentation. If not, feel free to send me an email. I'm always happy to respond to any kind of question or comment or discussion. And thank you so much for watching this presentation. I hope you learned something, and best of luck in all your future endeavors.